be knowing that this is a very important area, and may I disclose that the authors have no financial interest in any products mentioned in this presentation. Well, India has been gradually transforming from the safe, secure SICS to a more acceptable and a more reward-giving phacoemulsification surgery. The reasons have been our economy is getting every day better, and we can afford this surgery. Cataracts, we have worked hard, cataracts to SICS, and the cataracts are becoming softer. The machines are getting better and help us to deal with even the hardest of the cataracts, and the technology is becoming more Indian by the day. As I was talking to you, it is this wow factor that we get after phacoemulsification, which really scores over SICS, and the feeling that I have not been operated on the very first day, post-operative day of phacoemulsification. Well, we are all from Disha Eye Hospitals, and if you follow our statistics, this has been the total number of cataracts close to 40,000 now. And if you take the phaco curve, that's how it's following the growth of cataract surgery in our institution. Whereas if you take SICS, it is on the decline. So all said and done, we have to admit that we have to switch over from SICS to phacoemulsification. This course is all about how we're going to do that. Now, the first thing first, we do this surgery very well, and so we go ahead with SICS. First, let us understand that we must procure a good microscope and reasonably good phaco machines. The Indian machines with no financial interest from Swami are equally good. And then we should be trying phacoemulsification for almost every case. And how do we go about doing this? Is doing the SICS incision, but as you noticed, keeping the incision as close to the cornea so that we can use it for phacoemulsification. The normal SICS incision is kept very close to the limbus, and we should be choosing the ideal cases to start with, which means that you see that we make a small entry, a 3.8 millimeter entry. We stain the capsule with trypan blue so that it helps us to do a good rhexis, because phacoemulsification is an endocapsular technique and we need a good rhexis. To begin with, I would emphasize that we also need a big rhexis, because it should not come in the way of our phacoemulsification and subsequent procedures, and we can convert to manual SICS if we are in trouble. So we need to have the stain in the rhexis to see the rhexis all through the phacoemulsification procedure to begin with, and that is why I stain all the rhexis in the conversional stage. What is important in the conversional stage is to choose the ideal cases first, which would mean that you should not choose eyes which do not dilate properly, when the cornea is hazy, the exposure is not good, it is a deep set eye. At the same time, very soft cataracts and very hard cataracts are not good for phacoemulsification. So choose a cataract like this, grade 2, grade 3 cataract, which can be trenched, separated, chopped as per requirement. Keep using the left hand as much. In this video, see the surgeons using the left hand because this becomes an integral training of the left hand to move with the right hand as is required in phacoemulsification. We must not also choose eyes with poor red glows. Neither should we choose very shallow AC or hypermetropic cases, nor we should choose deep chamber cases like the myopic ones. At any point of time, if you are not comfortable, we can always convert and proceed as in SICS. So the emphasis is on the point that try phacoemulsification in every case to begin with. Of course, do choose your cases where you will complete more of them. And whenever you are in trouble, our good friend SICS, which we have been doing for so many years, is always there and we can easily convert. And the next video that we will be taking up with you, it's a both side simulation, because the wet labs parallelly are equally as important in training ourselves into phacoemulsification, because all that we need to learn as an SICS surgeon switching over to phacoemulsification is which cases to do, how to do it, and it's only about nuclear management, because we are always conversant with the rexes, the hydrodissection, and this is also important. To get accustomed with the phaco machine, this is the safest step which can be done first, the IA, the irrigation aspiration. And here there is a lot of epinucleus left as the surgeon will delaminate before the surgery. So, one good trick of getting these things out is to go catch a thing and then rub with the other left-hand instrument or irrigating instrument for cleaning up. So please understand that in all cases to automated IA, that is the first introduction to the machine, because all we can probably do is create a PC lens, then we can do vitrectomy and place in an intraocular lens. So this is the first step. The second step is, which goes on simultaneously and maybe before the first one, is to have your wet lab training seriously. You can set this up, there is nothing hi-fi about it. You can use the same microscope, the same thing, phaco machine. You need to take a roadside which you can easily procure from the meat shop, and you need to fix this eye properly so that it doesn't move during the procedure. If you don't have a Marty's eye like this, we will show you how you can just fix it on a thermocol board. The idea is that it shouldn't move during the training procedure. So you can have a thermocol block where you have created a small oval depression to house the both sides, and then fix the muscles with the both clips. The other thing that you probably noticed was to blow a little viscoelastic into the eye, so that the eye is very tight and you can actually carry on with this both side wet lab. The both side works extremely well because you can do an incision. Now you may be asking me why we are doing an SICS incision here if we want to learn phaco. This will become evident as the video goes on. As I wanted to tell you that you can do split the sclera and the cornea equally effectively in the both side. And here is the phaco incision. Viscoelastic is given to enlarge the incision. For the wet lab, we would recommend that you do a small rexis, because we need to house something here. Now the small, this is the best way to master the rexis also. See here the surgeon is trying an onion world rexis, which is slightly difficult art which needs to be done in hypermature cataracts, Morgagnian cataracts, and then sculpt a hole with the phaco machine in the boat's clear nucleus. So, and please note that the left-hand instrument is slightly inside into the cornea because the roadside cornea is very deep. So we need to have the chopper here and the phaco incision around here. Now we are enlarging the SICS incision. These pigments do come in from time to time, but you can always chop them in. Now the SICS nucleus that you have done the morning, or you can take your previous day's cases, they can be made hard by putting it in formalin for a day, and you can dial the same way. So you have to do the reverse what you do in SICS, dial the nucleus into that rhexis, and now you have a perfect simulation in the eye where you can actually go ahead and do phacoemulsification. You want to learn the chop, you can learn this direct chop. You want to learn some procedure, you want to perfect the procedure. What we want to convey is this is a perfect simulation, and if you do 20, 100 nucleus, you are not spoiling any human eye until you are sure that you can do it, and then only you can go ahead with your switching over to phaco from SICS in human eye. So yes, it is simple. If you can do it in the goat side, you can definitely do it in the human eye. The third area that I would like to take up with you is phaco-dynamics. We need to understand a little bit of this. Without complicating things, it is just an irrigation aspiration system where we have emulsification or ultrasound for harder things which we cannot aspirate. So this depends upon a gravity-free passive fluid system, which is the infusion, and this is the phaco machine that houses the motor, and this is the cassette, and this leads to a blue wire which takes the electrical signals to the ultrasound, and two tubings for the aspiration and irrigation up to the handpiece. So this basically is the instrument that we need to work with. Now most of these machines are safe machines, are peristaltic machines, and there is nothing great about it. It's like the way we used to fill up our old ink pens. So there are the tubings are pitched by the roller balls every now and then, and that is what causes the aspiration. So there is a motor which rotates these tubings around those roller balls. Faster the machine rotates, more is the aspiration flow. Slower the machine rotates, slower is the aspiration flow. As simple as that. So as I was telling you, it is phaco aspiration. What we can't aspirate, we emulsify and aspirate. So it is nothing out of the world, or those big machines shouldn't be scaring us. In foot position 1, irrigation is activated. In foot position 2, irrigation and aspiration flow is activated. And in foot position 3, all three, that is the phaco is activated, more important. Irrigation is a passive process in foot position 1, 2 and 3. When irrigation depends upon the bottle height, the opening size of the bore of the tube, the number of openings in the sleeve, the size of the sleeve size, the openings in the sleeve. But this is almost constant for a particular machine or a particular setup. And irrigation is compensated by aspiration plus a little bit of fluid which leaks from the sides. Now irrigation is more, the chamber deepens, and if the aspiration and leakage is more, the chamber will shallow. So if there is no aspiration or leakage as in foot position 1, irrigation is stopped by the intraocular pressure, which then becomes equal to the air pressure in the bottle. In foot position 2, there is aspiration flow, and greater the aspiration flow, more things will come to the tip of the nucleus. So when the tip is occluded by a nuclear fragment which is come, and the vacuum develops in foot position 2. Now, the preset vacuum which we have set, say 200, say 300, that determines that the motor will continue to rotate at the speed set by the aspiration flow, which is say 30 cc per minute, until the preset vacuum is achieved. So quicker the aspiration flow, quicker the vacuum develops. And as the tip is occluded, more fluid comes out at this stage and the tubings collapse. The vacuum is measured by measuring the collapse of this tube by a vacuum sensor. And when the collapse reaches the preset vacuum, that is say 200 or 300, the motor stops, thereby the aspiration flow stops. The vacuum again builds up, and the vacuum gives the holding power to chop and emulsify. So energy is delivered in foot position 3. As the energy is delivered, the occlusion is broken and the vacuum comes down. The tubings gradually swell, and the sensor activates the motor and the aspiration flow starts all over again. So the ease of collapse and swelling of the tube is called the compliance. The newer machines have better compliance or use less compliant tubing, so surge is minimized. They use stronger motors also. The compliance of the tubing is the most important thing that protects surge. When the flow is resumed, the whole cycle and the nucleus is occluded in the tip and the vacuum develops again. So this is the cycle which keeps on repeating again and again. So while we are trenching, we need power, but we don't need much flow. So we keep it between 15 to 20 cc. And the aspiration and the vacuum we also need not hold. So we can keep it at 40 to 60 to aspirate whatever nucleus we are trenching. But when we want to impel, when we get it, it's like hitting a nail in the wall, so we need a burst or panel or even continuous energy. And the flow should be 30 to 40 because we want to hold immediately after impelling, so it must be 300 to 400. The similar backmeters would work good for during the emulsification process also. Now this is to show that if we increase the irrigation, we are actually lifting the bottom height. See the irrigation increase and the chamber deepens. So this is to say that irrigation is passive, it is just dependent on the bottle height. Now to give you an example of the aspiration flow, you can follow the parameters here. As we raise the aspiration flow, you know this fragment which is not there, we are not moving the tip, not moving the fragment, we increase the aspiration and it has come to the tip. This aspiration of course 60 is not desirable. Now if we have the downside of having higher aspiration flows are this, the fragments cause a lot of turbulence in the eye, which is not good for the body. And now see the vacuum rise here. So there the energy is being used, the vacuum is held and the chock is executed. So the vacuum gives us the hold of the nucleus, the chock. So all through you see that the nucleus, the vacuum is high. So this is how you hold and then chock. Then during the emulsification process, please focus your attention to this part. See that this is the energy and this is the vacuum. See, they will always keep on jumping. The energy, the vacuum breaks again, develops, breaks again, develops, the flow stops, again it resumes. So this is a cycle, as I told you, which goes on continuously. Now if we are using too much of power without effective vacuum and effective aspiration, we will actually chatter the nucleus. It keeps on flying away from the tip. So that is called chatter. Now surge, for obvious reasons, it's been done in a category type. If you use too much vacuum, too much energy, what will happen? Things will happen very suddenly. The occlusion break will be sudden and the machine cannot take over, and that's how you have a incident here. So giving you a feel of what things can go wrong and what is the right way of doing things. Sometimes around this you see the vacuum is around 5 to 330, but nothing is happening, there is no hold. Actually the tubings or the tip has got occluded, so you need to prime the machine and change the tip. So these are machine problems which we have to solve on a day-to-day basis. Manush, our FACO trainer, enjoys an apple after every training session. So it's very simple. You impel, you emulsify, and enjoy FACO emulsification. Well, these were the first basics, and now we get into the subject proper.